Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
Hi, everybody. Welcome back to Neonatal Emergencies. This is going to be part 3. In our last couple of sections, we covered emergencies or common presentations to the ED for newborn babies. And then in part 2, we covered febrile neonates and how we manage them. Today, we're going to keep on going with some additional emergencies that you might find in newborn babies. So, like always, we'll start with a case. So, a 1-week infant presents due to quote unquote jerking movements. Mom noticed that as the baby fell asleep, he had a couple of minutes of rhythmic jerking. It seemed to be only the right upper extremity. Mom is not sure if the baby's eyes were deviated or if they were suppressible because she literally just kind of watched and was like, what's going on? Otherwise, baby is very healthy, born at term, has just gotten back to their birth weight, feeding well, no other infectious symptoms. On exam, she looks perfectly normal. Several minutes after your initial assessment, though, you're called back to the room because the infant has had several jerking rhythmic movements of that right upper extremity that were witnessed by a nurse. And so, what you want to be thinking about is A, what's going on? What are you going to work up and do about it? And what medications should we treat this baby with? So we're going to talk, of course, a little bit about neonatal seizures. So seizures in older kids are usually fairly obvious. Like we all know what a grand generalized tonic-clonic looks like. Absent seizures or partial seizures can be a little bit trickier to pick up. But in babies, even more true like myoclonic or tonic-clonic seizures can be difficult to really identify because babies often have kind of some weird movements that happen anyway. You know, they're just jerky little beings that move their extremities in weird ways as their neurologic systems are sort of still, forming and myelinating everything. So there are often things that will mimic seizures in neonates. For example, benign neonatal myoclonus is something very common, which is sort of that little enhanced, like startle almost reflex or little muscle twitches that babies will have when they're sleeping or particularly when they're falling asleep or waking up. Babies often have sort of uncoordinated movements in general, particularly sucking movements when they're learning to take a bottle. Disconjugate gaze or eye movements can be very normal in babies. Babies will often have esotropia or exotropia up until about 4 to 6 months of age, which can be completely developmentally fine. And so it can often be difficult to tell the difference between a quick little jerking motion or an eye deviation versus an actual seizure. So, true neonatal seizures can look like a lot of things, and they can also be caused by a lot of things. So, frequently we think about things like perinatal asphyxia, so like cerebral bleeds, hemorrhage, or like poor oxygenation in the first 24 hours of life. But we also consider things like infections and sepsis, metabolic derangements, so particularly hypoglycemia, and especially thinking about that in babies who were either small for gestational age or like infants of diabetic mothers. Other metabolic abnormalities like hypocalcemia or changes or abnormalities in sodium can certainly happen as well. And other inborn errors of metabolism may also present with seizures even outside of those abnormalities. So when we think about a neonate that might be seizing or who is having movements that we aren't sure if they're seizure or not, taking a thorough history can be very important. Was the baby born on time? Were they early? How was their prenatal care? Did mom have any labs? Were there any infections during pregnancy that mom is aware of, or any fevers during or after delivery? So looking for signs or risk factors for sepsis. We also want to ask things like, how is the baby feeding? Are we breastfeeding or bottle feeding? Have we been feeding well and appropriately? Are we putting on the weight that we're supposed to put on? If baby's bottle feeding in particular, it can be helpful to ask how the family is mixing the formula to make sure that we're not having an issue with electrolytes because of that. Um, and of course, you're going to do a very thorough exam and make sure that the baby has good tone, that there's no obvious like bruising, that the fontanelle is flat, and that there's no other obvious neurological abnormalities. Often we'll check at least basic labs on these babies. So, of course, checking a glucose is always very easy and quick to do and should be done in any baby with weird movements or really any concerns. But also checking electrolytes like calcium, magnesium, and sodium can be helpful. You can get some hints from your history and from these labs. So, for example, if they're not feeding well, or if there's any concerns for an inborn error of metabolism, so you might immediately think about hypoglycemia. If they are low, you can give them some D10 and try to correct that. If the family reports improper formula mixing, whether, usually by accident, but sometimes by intent, not malicious intent, but like trying to stretch the formula out. That can lead to hyponatremia. And if the baby is seizing because of a low sodium, you can treat that with hypertonic saline. Of course, if there's any signs of abuse, like bruising or a full fontanelle, then we won't probably want to get some imaging to make sure there's no like bleeding or intracranial hemorrhage. So if you actually think the baby is seizing and that this isn't a basic baby movement, a Moro reflex, a startle, those kind of things, then typically a seizing neonate under the first month or two of life is septic until proven otherwise. And so hopefully you've already watched our part 2 for our sepsis workups, but you're going to perform the full kit and caboodle with blood work, urine, LP, a head CT as well to make sure there's no bleeds. If there is a concern for a bleed, a full fontanelle, any bruising, then we will often also add on further workup for non-accidental trauma, like trauma labs, skeletal surveys. If you are working up for sepsis, of course, you're going to start empiric antibiotics. But to treat the actual seizure itself, if the baby is actively seizing in front of you and it's not just very brief, you can, of course, treat with benzodiazepines as first line, either Ativan or Versed. But in neonates, this is where things get a little bit different than older children because after benzos, in older children, you'll often see us move straight to Keppra as our second line. But in little babies, phenobarbital is actually the preferred second line in most cases. You dose it at 20 mg per kilo. And if that's not enough, then of course you can think about like Keppra or phosphonatoin in conjunction with discussing with neurology. But phenobarbital, especially if you're looking at a like a boards question that's telling you like a neonate who's seizing, if they're asking you about actual seizure treatment, then phenobarb is likely to be the correct answer. Okay, moving on from seizures, let's do another case. So this time we have a 3-day-old female who was born at home, but at term, came in because of some increased sleepiness, poor feeding, and working heavier to breathe. Mom says that the pregnancy and delivery were unremarkable and baby's been doing well, but they have had some issues with breastfeeding. The baby seems to get tired easily with feeds. She occasionally gets kind of sweaty with feeds. Hadn't really noticed any other issues until today when she started breathing fast and grunting right after she was finishing up a feed. They have not noticed any cyanosis, and she's not otherwise been ill, so no fevers, vomiting, diarrhea, or rashes. Her vital signs show that she is not febrile. Her heart rate is a little elevated, 200, breathing 70 times a minute, so pretty fast. And her blood pressure was low at 60/30, and that was taken in the left leg. Her sat probe, which is on her right thumb, is satting fine, 97%. On exam, she looks a little bit small. She is retracting, but her lungs are clear. She's tachycardic, but you don't hear any murmurs. Skin is mottled. Cap refill in the toes, in particular, is prolonged at 4 to 5 seconds, but her belly is soft, and you don't feel her liver or anything else like that. So you can start thinking. We mentioned in our last section that there are lots of things that can look like lots of things in babies, right? So you might initially be concerned that is this baby septic or infectious? Is this an inborn error of metabolism? What else could be going on? And how do we approach that sort of broadly differentiated or undifferentiated, sick baby? So in this case, if you were to get an X-ray on this baby, it would show the findings that you see here. And what you're looking at is a couple of different things. So number one, you can see these yellow, blue, and green arrows pointing to kind of this sort of almost like a 3 that it forms here on the right side of the screen. And then if you look at the red arrows, you can see what are actually some notching in the ribs. I think it's most obvious here in this like right upper corner. And those are all signs, of course, of a coarctation of the aorta. So I'm going to talk a little bit about coarc, but more broadly about sort of the neonate with undiagnosed congenital heart disease and how those can be managed in the emergency department. So statistically, a crashing neonate is actually more likely to be from congenital heart disease than true sepsis. But again, these can look very similar. So babies with congenital heart problems can present with shock due to obstructed blood flow to the body, such as in a coarc. They can present with cyanosis because of obstructed blood flow to the lungs, such as with like pulmonary atresia or TGA. Or they can present with like what looks more truly consistent heart failure with like pulmonary edema and liver or hepatomegaly, but that is more rare. So a lot of times these babies come in just looking sick. They look dusky, they're lethargic, they're feeding poorly, they may be breathing hard, they may not be gaining weight well. And again, all of that should sound somewhat familiar if you've watched our sepsis video, because of course, those are all things that babies can present with sepsis. And so it, again, can be very difficult to tease this out. And it's never a problem if you're kind of looking into and treating both at the same time. The classic story of always fine except working hard to breathe with feeds, tiring early with feeds, sweating with feeds, however, is very classic for congenital heart disease because babies really like eating is kind of the most exercise that they do. So they work hard when they're eating, and it's almost like having dyspnea on exertion or symptoms with exercise that you might see in an older adult with a similar heart problem. On exam, you might see things like tachypnea, tachycardia. Sometimes you'll see hepatomegaly or crackles in the lungs, but not always. Poor perfusion is often a finding as well. So one of the first things you can easily do if a baby comes in blue or having trouble breathing is just to put oxygen on them. So you'll call this the hyperoxygen test. Sometimes you'll see it called, but it's basically trying to figure out, do they respond? So if a baby is working hard to breathe, retracting and blue, and you stick an oxygen mask on their face and it gets better, that is much more likely to be a lung problem. Whereas if it does not improve, you're much more likely to be dealing with a heart issue. So I can sometimes not only help treat the issue, but also give you a hint of what's going on. Other things to look for, remember that you may not hear a murmur. Big open VSDs or similar lesions will not necessarily hear a murmur because they're not really restricting flow. Lung exams are often normal. They may have some crackles if they are severely in congenital or sorry, congestive heart failure, but not always the case. On chest x-ray, you may see cardiomegaly or abnormal circulation. Um, an important one, and one of the reasons that I put this detail in the case is that you can see a differential in their oxygen saturations. So they will often be higher on the right hand or wrist or fingers than they are elsewhere, particularly if this is a ductal dependent lesion, because you're getting more blood flow out to that side of the body pre-ductus arteriosus than you are post-ductus arteriosus, which would be the left hand or the legs. Um, if you have what's called a reverse differential saturation, so like it's lower sets in the right hand or wrist than elsewhere, that is a sign of transposition. And of course, you can also consider things like a low four extremity blood pressure. So if you're having more prolonged capillary fill in the legs than the arms, or lower sats in the legs than the arms, or you're having trouble feeling femoral pulses, a four extremity blood pressure is also a great, quick, and easy test. If the blood pressures are much higher in the upper extremities than the lower extremities, that is a clue for coarctation. So we always remember back to our very early days of med school, but remembering that the cyanotic heart lesions are the 5 T's. So that would be your truncus arteriosus, your transposition of the great arteries, tricuspid atresia, tetralogy of Fallot, and TAPVR. Hypoplastic ventricle, classically hypoplastic left heart, is again another cyanotic heart lesion. But the 5 T's are generally like the big boards ones that they're going to want you to remember. And I always use the mnemonic of 1, 2, 3, 4, 5 to remember them. So the 1 is a truncus because there's only one vessel exiting the heart. 2 is for TGA because you have two vessels that are switched. 3 is for tricuspid atresia. 4 is for tetralogy of Fallot because four things are wrong. And 5 is because just easily TAPVR is 5 letters. Your non-cyanotic congenital heart lesions are the Ds. So your ASD, VSD, and then also an AV canal, which is kind of a combination of both. And then a coarctation can be cyanotic or not, depending on how critical it is, where it's located, etc. In general, if you suspect a congenital heart lesion, the first thing you should be doing is A, putting some oxygen on them and see if you can fix it. B, if you think that this has any potential to be a ductal dependent lesion, start prostans immediately. Even if you're wrong, better to start the prostans and be wrong than to not start prostaglandins. And you can see the dosing here. This is something you're never going to be asked about as far as like boards or anything like that. But things you should know, beyond just the dosing is that the effect of prostans can take a little time. So don't freak out if you start them and it hasn't like fixed it immediately. It can take up to 15 minutes to take full effect. And importantly, be prepared for side effects. So prostaglandins will almost always cause apnea in patients, at least briefly, if not more persistently, and can also cause hypotension. So if we're starting prostans, we also should be prepared to intubate the patient. If that doesn't work, if prostans aren't enough, then we will often start inotropes like milrinone. And of course, hopefully, as you're putting all these orders in, somebody, you or your attending or your fellow or somebody else in the ED is also calling cardiology, getting a stat echo to come down and see what's going on. Of course, if you're worried about a congenital heart problem, you do want to use extreme caution when giving any fluids. And you don't have to be perfect. So we don't necessarily actually want to get their SATs all the way up to 100 if they're low. But targeting to like 75 or 80 is actually pretty adequate because you don't want to cause them to reflexively decrease their flow to the vascular bed, which can happen when they become fully oxygenated. Um, Pulmonary hypertension is also a significant emergency that can be very tricky to identify, but is increasingly seen in or recognized to be an issue among cyanotic neonates. So if you have, the baby who comes in looking ill, they're blue, they're in respiratory distress, particularly for whatever reason in larger babies, like post-dates babies, what happens is they have constriction of their pulmonary arterial vasculature, which causes hypertension. And then you end up with right to left shunting of blood through like a PDA or a PFO, which then leads to hypoxia and cyanosis. Similar to other congenital heart issues, these will generally not respond to oxygen. You may see a higher sat in the preductal right hand. And so, if that's the case, you're probably thinking about a ductal dependent lesion, starting prostaglandins. If that's not working, this is a possibility and something to consider. And what you do in this case is actually hyperventilate them. You want to increase their O2 and decrease their CO2 in order to dilate the pulmonary vasculature. And nitric oxide is also something that can help, but ultimately these babies may need ECMO. And again, that's not something that you'll be making a decision about in your job as a resident, but it's something just to know and be aware of. The real takeaway for congenital heart issues are that if you have a baby who is very sick appearing, particularly if they are having trouble breathing, poor feeding, if the issues are worse when they're feeding, or other like circulatory or respiratory effects, don't be afraid to think about the heart in addition to thinking about things like sepsis. Don't be afraid to start prostaglandins, even if you're also still getting a septic workup and starting antibiotics. Those things can coexist, and you may not know until you get all of that workup back. I'm going to wrap up this particular section with one more case of a parent who brings in their 3-week-old due to concerns that the baby is breathing funny. She had an episode today where she started breathing fast and then held her breath for about 15 seconds. The parents tapped her feet, blew in her face, and then things fixed themselves. She came back to normal. She was never cyanotic. She never changed any tone or went limp. Otherwise healthy, growing well, no medical issues, feeding fine. But they're very, very worried about this breathing pattern. They were totally convinced the baby was going to die, and they are just stressed to the max. On exam, this baby looks great. They're back to baseline. And so, again, we got to think about what could this be? Is it something serious or not? And what do we do? So respiratory emergencies in neonates can be anything from infection like pneumonia or bronchiolitis to true apnea, whether that's like a BRUE or apnea of prematurity, but can also be like weird things like congenital diaphragmatic hernias and even benign things like periodic breathing and tracheomalacia. Things that are benign, so periodic breathing, super common and a common reason why parents might kind of get upset or freak out and not know what's going on with their baby and why they're breathing funny, and therefore show up to the ED. Basically, these are sort of these waxing and waning up and down periods of they'll basically alternate between tachypnea versus sort of apnea. I put that in quotes because true apnea is nothing less than 20 seconds. So if the baby is quote unquote holding their breath for 5 or 10 seconds at a time, that's actually not apnea. It has to be 20 seconds or more to truly be apneic. Now, that said, if you're a parent and you're watching your baby breathe and they're holding their breath for what seems like forever, they may not know how long it was, and it's certainly reasonable that they would be very scared. With periodic breathing, there's no color change, there's no cyanosis, and this is a totally developmentally normal thing. It's basically just baby brains learning all of the ins and out of being a baby. And so if the parent describes something where the baby is kind of alternating between and they go back and forth between that faster breathing, kind of a pause, and then slower breathing, that is periodic breathing. They are fine. If the baby is turning blue, having color change, or holding their breath longer than 20 seconds, of course, it's not periodic breathing and requires a little more workup. Tracheo or laryngomalacia is also a common sort of normal thing that babies will come in with. They're often just sort of making a lot of noise when they breathe, whether it's usually stridulous, so inspiratory noises, but can also include some expiratory stridor. It's typically worse when they're supine. So if they're laying on their back, because they have basically floppy airway, and so that gravity is pulling the airway in, and they make these like noises. If you flip them on their belly and it fixes it, you've solved the problem. This is what this is. It's laryngomalacia or tracheomalacia. However, these babies should have no other things that are red flags. So they're not turning blue. They're not truly apneic. They're not retracting with it typically. They're growing well. They have a normal exam. And in general, if those are all the case, and it's better when you flip them on their belly, these are fine. They will grow out of this. If it's particularly severe, then you can refer them to ENT. BRUE, by contrast, is sort of this like nebulous event that happens where we don't have a good reason, but the baby did something that really scared mom and dad. So, kind of like this case. BRUE replaces the old mnemonic of ALTI. So, ALTI stood for Apparent Life-Threatening Event. BRUE stands for a brief, resolved, unexplained event. And you can, I mean, what it is literally in the title. These are events that happen between 0 and 12 months of age. They last less than a minute, and they include at least one of the following. So either the baby got pale or looked blue to the family, they had some sort of change in their breathing, where it was either they held their breath or they were breathing irregularly, they had a marked change in tone, or were not as responsive as normal. In order for this to be classified as a BRUE, it has to have lasted less than a minute, and they have to be back to their baseline by the time you see them with no other condition to explain the event. So if they are bronchiolytic, pouring snot, that kind of stuff, it's not a BRUE because it's bronchiolitis. If it's very clearly reflux, where they had just fed, they had a massive spit up, and then they like went stiff or held their breath for a minute, again, it's not a BRUE, it's reflux. So a BRUE really has to be a diagnosis of exclusion. In general, you break BRUEs down into high risk and low risk. So a low risk BRUE is a BRUE in a baby who is more than 60 days old, was born at more than 32 weeks, is now, of course, more than 45 weeks old. So they've, made it to 60 days. They've never had one of these before. Nobody who was a trained provider did CPR. So if the family like gave a couple back blows or a couple chest thrusts, but like has no idea what they're doing, that doesn't count. If EMS gave CPR, that is no longer a low risk BRUE. Um, for it to be low risk, they also can't have any concerning historical features like potential abuse or toxic exposures, or any worrisome physical exam findings like a murmur, a BRUE, hepatomegaly, that kind of stuff. If the patient meets all of those criteria for a low risk BRUE, there's really not a whole lot that's necessarily required for you to do. The recommendations are that you may get an EKG, which I think most of us will usually do. You can check them for things like pertussis or other viral testing. You can observe them for a while, maybe observe a feed, put them on the monitor, make sure their oxygen is okay. You can offer CPR training to the caregivers, but there's no definitive need for any further workup and not recommended for them to be prescribed like reflux meds or antiepileptics. However, if they are high risk, so if they do not meet the criteria that we specified in this slide, then really workup is kind of at the discretion of the provider. So for us, that may include things like a head CT, an EKG, if they're having respiratory symptoms, perhaps a chest x-ray. If they've been febrile or otherwise sick, you might get some basic labs, again, viral testing. If you're thinking, could this be a seizure, we might get an EEG. And oftentimes, if there is anything potentially high risk about these, we will admit them. Even if they're low risk and the family's just freaked out, admitting them for obs overnight is never a bad idea. And so that's probably about 50-50 in the low risk population, but most of our high risk patients. So the takeaway is again that if there is an obvious diagnosis like GERD or a breath holding spell, this is no longer categorized as a BRUE or an ALTI. If there's no diagnosis, but they are low risk, then you don't have to do a lot of workup. But remember that if they are high risk, and that includes neonates, so under 60 days of age, really doesn't count as low risk. So if this baby who's only a couple of weeks old has an event like this, then you go to your high risk algorithm and you can really kind of do whatever workup is appropriate and likely admit them overnight. And we'll pause there and come back for another round in another episode. Thanks, guys, for watching.